Well, I think we have to start just to keep in the schedule. And thank you very much for staying till very late tonight. And just to introduce myself, my name is A.RADY. I'm Associate Professor at Alexandria University. I work as a psychiatrist and as a clinical psychotherapist. And I started working with psychotherapy 15 years ago, and I was focused on the cognitive behavioral therapy as a first instance. And then as more and more I practice, I find that patients are not like what's written there in manuals, and there's some sort of gap between what patients is supposed to behave according to manuals and what do patients do in real life. And so I started to be interested in more psychological schools. So I went for some time with hypnosis. Then I went for the systemic therapy, which influenced me a lot in understanding the reactions and the relations between different persons and the different social models. So my main interest in this workshop is really to identify those patients who are showing some sort of resistance during a natural course of CBT, and how you can manage this resistance by using different communication skills, if we can call it like that. And those communication skills are based on the neuro-linguistic programming, or the indirect hypnotic, as the indirect hypnotic communications that have been developed by Erickson. So these are the objectives. We will identify the motivational level of the patient, which is always overlooked by most of psychotherapists. And then we will take a look over a half an hour for the principles of CBT for those who are not professionally practicing cognitive therapy. And then the basic models of integrative psychotherapy, or how can we integrate different schools together. And finally, some initiation of those simple communication techniques that we can use inside the psychotherapeutic process. Well, I always like to start by these slides in all my workshops in psychotherapy. And as you see here in this slide, it shows all kinds of psychotherapy that can be plotted, practically speaking, on this graphical plotting graph. We have on the vertical axis the presence of psychosis, of loss of reality sense, and on the horizontal axis you have exploratory at one end and supportive at one end. And as you find, the CBT is present in the middle, so that you are between exploration and the support, and you can use it with maybe persons at the middle, not so psychotic and not normal personnel as well. So all psychotherapeutic modalities can be plotted against this plotting graph, and there are so many psychotherapeutic modalities nowadays, to the extent that the World Council for Psychotherapy is identifying 18 scientifically distinct psychotherapeutic modality and 22 complementary technique. So how to assess this desire of patients to change? Because the psychotherapy is a process, it's a journey to change somehow. And this change model of Prochaska and de Clement is very famous for those who are working with drugs of abuse. But if I'm going to talk about the pre-contemplation, those patients who are completely denying the problem, and they are not contemplating, they are not questioning themselves whether there's a problem or not, and then getting to contemplation, they feel that there is something wrong. Maybe it's not the psychological problem itself, but there is something going wrong after all. And then they take the decision, and after all, they take an action. They maintain a positive action, and then there's a relapse. This model is always famous for addiction. But in fact, this model can be extended to all processes of change. It's not specific for addiction. And by the way, it was not invented in that sense. It was not invented for drugs of abuse, but it has been more or less used in that specialty, to the extent that Prochaska and de Clement cycle is always associated with the domain of substance abuse. So Freeman and Nolan in 2001 proposed a whole scale to evaluate to whether the patient is really motivated to go through psychotherapy or not. And this scale put the patient from 1 to 10 according to his position to psychotherapy. Most psychotherapists, in fact, do not assess such changing cycle, but they are just proposing psychotherapy, and then they work with the patient, and they do overwhelm, or they overcome this reality that some patients are not, in fact, in the stage of action, and they are not in the stage of planification of action. So they sometimes regress back to contemplating whether this psychotherapy will work or not. And sometimes they get even a more position against the psychotherapy, getting a pre-contemplating position, or sometimes getting even anti-contemplating position by attacking the psychotherapist. And how to identify patients on that scale, it seems for me very interesting, though no many psychotherapists are doing that. So why do psychotherapy find some sort of resistance? This is not specific for the cognitive behavioral therapy, but this can apply to all psychological intervention. Some patients, I don't want it, simply I don't want to change, I don't like psychotherapy. And for me, I think that the proper answer for that is psychotherapy is like medication. It's a medical act. And medical acts are not done to be loved or to be liked. We don't like medications, and medications are not supposed to be liked. We have to take medications because we have to reach a certain goal through those medications. And this is how it goes with psychotherapy. Cognitive emotive resonance is a very important concept. Whenever you do something that you are not accustomed to, you feel some sort of discomfort. If I'm behaving in a different way, different than the way I'm accustomed to or I'm habituated to, I will feel some sort of discomfort. And this discomfort feeling is very common, and it's called emotional or cognitive emotive dissonance. And simply as far as you get more and more habituated to the new adaptive behavior, you will get this anxiety or discomfort feeling disappearing. And when you adopt a new adaptive behavior, you will find a new discomfort feeling comes, and so on. So it is the same way as if I'm asking a right-handed person to write with his left hand. How does he's going to feel? He will feel some sort of discomfort, but he is absolutely able to write with his left hand, maybe with not very good quality. But if he is writing with his left hand over 1 year, he will get accustomed to writing with his left hand. And what comes in when 1 year after you will ask him to write with his right hand again? He will feel the same discomfort back again, and so on. So this cognitive emotive dissonance should be explained to the patient and why he feels discomfort. Symptom stress that has been described by Albert Ellis in 2002 means some people are saying, I have nothing going bad in my life, but I'm very depressed, that I'm getting depression, though I have everything is good. This is what we call a symptom stress. So I'm depressed because I'm depressed, and I'm anxious because I'm having an anxiety, though everything is going fine in my life. And I feel shameful, and this has to be addressed because of the long psychotherapy. If you are proposing a psychotherapy over several months, one patient will ask you, am I severely mentally ill to be in need of such psychological help for longer periods? And then after taking the decision, or after putting the patient in action and starting the course of psychotherapy, I will just try to explain in brief how the standard CBT goes on. It always starts by defining the goals. And the goals are sometimes ill-defined by patients and even ill-defined by psychotherapists themselves. If you ask one patient, what are your goals in life? And then most of patients will tell you that I want to feel happy, I want to have a better family life, I want to have a better social life, I want to be more confident. And according to the basic definitions of CBT, such goals are not valid goals because in fact they are general desires. If I'm asking you, I want to be happy, all people want to be happy. But to identify a proper goal, you have to ask yourself, what are you going to do when you are going to be happy that you are unable to do just right now? because you are unhappy. And such a specific question really describe a specific goal that has a time frame and a very clear definition, so that you can ask yourself, where am I in relation to the goals I'm setting. So here are the questions: what I want to do more, what I want to feel more, what I want physically to feel more, and what do I want to think more. But always ask that question: is it a desire? Is it a mean to achieve a goal, or is it a true goal? Because the patient has to identify very clear goals before therapy. And I do prefer the nomenclature, because there is no one CBT. In fact, there are a lot of CBTs currents, but I do believe a lot in the life rational therapy that is developed by Aldo Pucci, the current president of the National Association of CBT in the United States, because in fact the CBT has to be considered as a philosophy of life rather than just tackling one problem and getting it over. So you have to set goals, and then the importance, you identify the importance from 0 to 10 scales. Just 10 is the very important goals for you, and 0 is goals that are less important. And the filter effect, as proposed by many authors in CBT, because sometimes when you ask a patient to think about his goals, the patient is trying to find goals that seems to him as a good answer for you rather than his own goals. And you have to be clear that the patient is not filtering what's good and bad. He just has to put what are his goals in life. And the best way to do goals, this is the way I'm doing it practically, is just in the first session I'm getting a piece of paper, then I'm making a lot of circles, and I tell him, how do you see your life? How can you evaluate your life if we take an estimation or a scale from 0 to 10? 10 means that you have a very happy and the happiest life you can ever have, and 0 you have a very bad and a miserable life. So how can you evaluate your life? And sometimes patients are asking, I'm unable to satisfy or to answer that question. And the next question I'm addressing to the patient is, you see these circles? These circles are in fact your life. Life is multidimensional. So life as a concept is a very global term. What is life? Because always as a philosophy of life or a CBT, you have to identify things and dividing it into components. So life has a social aspect, they have a professional aspect, they have a financial aspect, they have a health aspect, they have a family aspect, they have a spiritual aspect, they have a moral aspect, and etc. So as far as you find a lot of circles, so what are your goals in those circles? How do you see your life in those circles? And most of patients, when they are giving themselves a very bad score at the beginning, when they look to their life globally, do it much better and give a higher score when they see their life in the form of multi-dimensional model rather than seeing their life globally. So after setting the goals, we start by the functional analysis. And the functional analysis is the tool with which we can detect the maladaptive behavior, the situations at risk, as well as the automatic ideas or the automatic negative ideas. And this is the most basic way to do functional analysis, though it has been described 60 years ago with a lot of other modalities, maybe more advanced, to go for functional analysis in CBT. But in my opinion, the ABC is very simple and appealing even to patients. The ABC stands for adversity, belief, and consequences. And so any situations where you find you are distressed, simply you have to identify what is the adversity, what was the situation by that time, what are ideas or images that came to your mind by that time, and what are the consequences, means how did you feel and how did you behave. And this model is very interesting because our feelings are the result of how do we think and not the opposite. So we do not think bad because we feel bad. In fact, we feel bad because we think bad. And this is very something that's really very interesting, and it's a good thing in its own property, because we cannot change situations, in many times we are unable to change the situations, but we can change our way to view the situation, our way to interpret what happens. And so as far as you have difficult situation and you have a flexible and constructive way of believing system, so you will have a constructive behavior. On the other hand, if you have difficult situations and you have a rigid and absolutistic way of believing it, so I have just an assumption, a negative assumption, and I'm behaving as this assumption is a reality, and not only assumption. It's not a hypothesis, it's a reality. And then I have self-defeating and destructive consequences. So to overcome this ABC model, Albert Ellis added the D letter, which stands for dispute, so that the automatic thoughts should be disputed against reality, whether those type or those kind of believing system is really valid or not. Here are some models, like the SORC, the basic idea, which is a very comprehensive one. You have the behavior, the affect, how did you felt in your body sensation, how that affected your interpersonal relations, what kind of ideas came to your mind, what kinds of images came to your mind, are you receiving drugs or not, what were you expecting, and what really happened. And as more and more elements in functional analysis you find, the more levels of intervention you may propose. But it's too complicated for patients, in my opinion. And this is the Gray Secca by Cotreau in Paris, and it's emotion, cognition, consequence, anticipation. And here's the 3-column table by Beck. This is how the assignment is given to the patient. You will ask the patient, whenever you feel that you have been through a distressful condition, just fill this table, 3-column table: situation, emotion, and what came to your mind at that moment. And this is the vicious circle model of Charlie Kanji, which I personally do prefer. It's very simple to the patient. You just give the patient the same of this figure as a model for the assignment, and whenever there's a situation, he filled the circles. What's the situation? How did he feel? What came to his mind? And how did he behave? And this behavior produced some consequences on himself and on his relations to others. And this is one of the simplest model I do prefer to use in practical basis. So whenever you find those functional analysis, the patient will come maybe for 1 or 2 sessions, and having exposed a lot of situations where the patient feels some sort of psychological stress. And as we have different components of this functional analysis, we may propose interventions that are adapted to each element of those components. So for the situation, you will find that there are situations that provoke low mood, or provoke an anxiety, or provoke bad sensation, and to what extent it is really pathologic, and is it avoidable or not, and if it's not avoidable, what are the alternative to that situation? What can I do to alleviate the stress? Because many people are doing a lot of things, in fact, without putting some time to understand what are the priorities for them. So they have the impression that they have to do a lot of things in a very short time, while in fact they have to prioritize what they should do and what they should delegate someone else to do, and what they have to quit, because you cannot do everything. And after that comes the emotions and the how do you react emotionally. And for that you teach the patient the relaxation techniques, and most of them, there are many relaxation techniques. The most famous of them are the Jacobsonian, based on the contraction-decontraction, and the Schultz with the progressive suggestions of heaviness of each part of the body. And then comes the level of the cognition. And here's the cognition. this is the assignment of the 3 column, and you ask the situation, how do you feel, and what do you think by that moment. And if there is an automatic negative thoughts that produces such a low mood or an anxiety, you have to replace it by an alternative thoughts. And finding an alternative thoughts is not very easy, but it comes with training. So we have several exercises. Unfortunately, we don't have enough time to go through some exercises with that because of the tight duration for this workshop, and to make a more focus on the hypnotic techniques at the end. So there's the two-sided argument. So whenever the patient has a certain belief, then you have simply to pose this rational questioning. And this rational questioning is very important as a concept, because in CBT we are not here to run the family or run the life of patients on behalf of them. So it's not for us to identify what's right or wrong. It's simply to find whether the way the patient is behaving, whether the way the patient is feeling is going with his goals or against his goals. So whenever the patient is identifying his goals and he get into a distressful condition, we have to ask those 3 questions. Is my way of thinking is based on a fact? And the second, does the way I'm thinking is helping me to achieving my goals? And the third one, does my idea or my way of thinking is helping me to have control over the way I'm feeling? If any answer for those 3 questions is no, this means that the way I was thinking at that situation was irrational. I'm not talking in terms of right or wrong. It simply doesn't go with my goals. And so you are testing this idea with 2-sided arguments. What are points with and what are points against? Though this is the standardized exercise for most of CBT manuals, but when it comes to real practice, and you are facing a moderately depressed patients, for instance, and you find what are the points in favor, you will find a lot of arguments. And when you find what are the points against the way you believe, you will find none. And this is the true answer of a true patient. And it's not like in manuals finding a lot of points with and then a much more points against, because his anxiety and his depression is in fact blocking a logical way of thinking. And so in real life, these 2-sided arguments, in my opinion, doesn't work that fine except in manuals. So if you go to the changing role technique, which is a very common strategy in CBT, so in order to find solution, then let's make a role play. And you know that if your friend is getting some sort of distress or psychological suffering, what usually you do have with him? Do you assure him? Do you try to help him psychologically? Well, in most of cases, yes. Then let's play that role play, and I will act as if I'm your friend and coming to you asking for psychological help. And then I'm trying to encourage the patient himself to find a more ideas, a more helpful idea for me. And then as far as I find that the patient is able to find an alternative way of thinking, an alternative interpretation, I get out of this role playing and I ask him why, if we cannot apply those ideas you just suggested to your friend, to yourself. And then come the descending arrow technique. Descending arrow techniques can be used in 2 ways. In fact, one way is to try to bring back the logic way of thinking into mind. Sometimes anxious persons are very catastrophizing things, and they are jumping to conclusion. Whenever there's something is going wrong, they jump directly to conclusion that something catastrophic should take place. And what we are doing in this descending arrow technique is simply you start by the situation and the conclusion at the end, and you make several lines by your pen, and then give the paper back to the patient. What will happen between the situation and the conclusion you made? What happens in most of cases that the patient writes 1 or 2 or 3 lines, and then he starts to laugh. Simply he got the idea that there's something illogic that he is trying to put. So this is one way. Simply you are calling the logic part of your mind back again to be put in action. The other way is to search for a more profound, what we call the core beliefs. So supposing that I have the catastrophe and I find that what the patient is saying is not really going with the intensity of emotion the patient is experiencing, then we will start by the catastrophe itself and ask the patient what will happen after. I mean, even if the patient is suffering from panic attack, for instance, and then he will tell you, then I'm going to die, and we are going really to tackle that painful issue and say to him, I know that it's very painful, and how do you imagine things are going to happen after death? So what really is important here is just to carry what happens from the catastrophe till the end, because you will find that the patient is really has a lot of concerns, not about himself only, but also about what will happen to his family, his wife, his children, how it will be disastrous after his loss, and so on. So as to tackle a sense of insecurity. So it either goes by both sides. And here are the some of the automatic irrational thoughts. For the automatic thoughts, you have Albert Ellis and Beck, who described 10 main automatic negative thoughts. And they said that even when you are feeling pathological, in fact, you are thinking in a structured way. But the structured way you are thinking with is pathological. It says that, as Mopsley says, and I always like to quote that phrase for patients, Mopsley was saying that supposing that I thought the same way you thought, I will feel the same way you feel. The problem is that you have a normal brain, and that's why you have felt like that, because simply if I'm thinking the same way of you, I will have the same depression or have the same anxiety. So the fact that you are depressed or you're anxious means that your brain is working fine, but you are using your brain in incorrect manner. So I will expose those 10 ideas and even the expanded 27 automatic thoughts that have been proposed by the National Association of CBT in the United States later on. So all or none thinking. I mean, nothing is in fact all or none. The dichotomic way of thinking is unacceptable in CBT because there is always a gray zone. So I cannot be very good or very bad, but I can be good in certain things and bad in others. I will come across them very rapidly. Overgeneralization. Whenever you generalize anything, so all people are bad, all husbands are cheaters, and so on. Whenever you are generalizing, this means that it has no true foundation. The mental filter. The mental filter is concerned about labeling people with things. I mean that you are blocking certain data in the environment, and you are only accepting one explanation for the situation, but not other interpretation. Discounting the positives. They always discount the positive parts of what they did. Jumping to conclusion without any foundation, without any evidence or any supportive data. Mind reading, and this is very, very important as well, because many people are mind reading others. I mean, I know him well. I know how he was thinking at that time. In fact, what we are teaching the patients is that no one can exactly tell what really goes in the mind of any other person. What you can tell is that if one person is behaving in a certain way in a certain situations, and this behavior has been repetitive when the situation is repetitive, so you can predict his future behavior. This is what you can do in fact, but you can never tell what really goes in his mind. And the second thing is that nothing among the goals of any patient or among anyone to do anything is to have a a positive regard from all other persons, because this cannot represent the goal to do anything. The fortune telling, as in fact, why should I study? I will fail anyhow. This is what we call fortune telling. Um, just expecting that I'm going to fail. So this is a fortune telling, because it should be based on fact. The magnification of any problem, the emotional reasoning, and this is very common among anxious patients and depressed patients. Suppose that I entered this room and I felt that I'm afraid. Does that mean that the room is fearful, or does that mean that I'm feeling afraid? So the question is what we call the gut thinking. The emotional reasoning is simply you think based on how do you feel rather than the reality. And this is very common among pathological patients. When I feel anxious, then this means that there's something going wrong. When I feel afraid, then there's something fearful. When I feel ashamed, this means that people are regarding me with negative regards, and so on. So what you should see is only facts in front of you. This how do we deal in rational CBT. So the emotional reasoning is called the gut feeling or the gut reasoning, because simply you are reasoning things, or you are building up your thinking based on your body sensation. The irrational labeling, when you are asking yourself that I'm very stupid, I has always been a big failure, I have been always been a dump, and you are asking him what a dump should look like, and this really has to have a very clear identification, because in fact the bad labeling is always doing a very bad thing, is what we call autorealizing hypothesis. I mean, as far as I'm telling myself that I'm dumb, I will react as being a dump, and so on. Personalization and blame. In all situations that goes wrong, usually depressive and anxious personnel have the tendency to blame themselves for any failure. But any failure has to be analyzed according to the three components that do exist in any situation: me, others, and the conditions around. So I can carry part of the responsibility, but I should take in consideration how things were reacting and what the conditions around was by that time. Irrational shoots, and this is by far the most important automatic thoughts that really hinder someone from thinking positively or rationally, because all of us has a certain set of how life should be, and how one should behave, and how one should be dressed, and how one should talk, and how one should eat, and how one should drink, and how one should enjoy his life. So these shoots is built up over time according to a certain reference system in mind. And the problem is that you do feel that people have to imply to your rules, and they should do a lot of things, while in fact they shouldn't, because there's no definite rules about what people should do except in your mind. So the shoulds is one of the major automatic thoughts, and I do believe in the systemic therapy belief. Do anyone here in this room is practicing systemic therapy? There's a big pillars for the systemic therapy, and one of those pillars is the reality concept. And I do like the phrase of Professor Paul Václavic, when he says that there is no right or wrong, there is simply something and something else. And I do like that phrase, because it really changed a lot of things in life. That's why he was one day talking about intelligence, and at the end of the lecture he said that intelligence, after all, is simply what you measure by the intelligence test, but in fact it has no clear definition till now.